allow me to introduce myself. I'm Ken Young. I'm from the MPN Alliance Australia. I'm a PV patient. I was diagnosed back in 1997. And our organisation works very closely. We're a volunteer, an independent volunteer organisation of the Leukemia Foundation of Australia. And it's a great pleasure to welcome you all here, whether it's this afternoon, this evening, or in my case, this morning. I'm located here in Melbourne on the lands of the Bunurong people of the Kulin Nation, and I pay my respects to their elders, past, present, and emerging. This will be, now that we haven't been able to meet at Horizons, this is going to be the start of a series of Zoom meetings that are aimed and targeting the advocates networks, so that you can have the information that you need to pass on to your organisations. Now, I'd like to introduce Kapila from the MPN Research Foundation in Chicago, and she's going to tell us a little bit about herself and then introduce Dr. Claire Harrison. So, Kapila. Sure.
Thank you, Ken. Appreciate the opportunity to get to know this community a little bit better. As Ken said, I'm Kapila Vaidis. I have taken over at the MPN Research Foundation, somewhat in partnership with Michelle, as she has continued to champion on our behalf with the MPN Advocates Network. So it's been quite a smooth transition as I've come into the foundation and continued to work with Michelle, and now start to get introduced to this group. And so I'm very excited to get to know all of you and come to learn about all of our global partners as well in this fight for MPNs. So I have been at the MPN Research Foundation about 6 months now. I started in the fall, September, and have just been, in addition to getting to know the community, advancing our research efforts and working with our team to ensure we are continuing to push the needle towards new therapies, new research for better patient outcomes. So just excited to be part of the community, and thank you all for a warm welcome. With that, I actually want to quickly introduce Dr. Claire Harrison. I think we're very fortunate today to have her with us. And in the interest of time, I know we're eager to hear more from her. And many of you already know her, but just by way of introduction, she's coming to us from the Guy's and St. Thomas Hospital in London, and has focused for quite some time now her translational research and clinical research efforts around improving diagnoses, understanding risk definitions in MPNs, and then again, furthering our knowledge and experience with therapeutics for MPN patients. She is a great advocate for both patients and for advocates, and has founded and worked with organizations like ours, the MPN Research Foundation, the MPN Voice, and other organizations like this. So we're very grateful to have her in the community. I'm sure many of you know her well. And we're just excited to hear the updates from the ASH 2020 and her perspective on some of the learnings and findings that were presented in December of last year. So without further ado, I'm going to actually hand it over to Dr. Harrison and thank her for joining us today and pulling this presentation together for us, and let her kind of talk through that. If you have any questions or comments, we do have a Q&A session at the end. So please feel free to either use the Zoom chat, add your questions there, and then Ken and I will kind of help facilitate that discussion towards the end. So please do use that feature to let us know if you have any comments or questions. So Dr. Harrison, I will let you drive from here. Thank you.
Okay, well, thanks very much. Thanks everyone for warm welcome. Always plenty to say about the ASH meeting. first of all, to say it was a virtual meeting, and that meant there was lots of opportunity to go back and look at things, but not so much opportunity for networking and meeting peers, which we all missed a lot. But we can all all of us get used to this kind of technology and use it to our best. So what I've tried to focus on in these slides is really very much about quite a lot about therapeutics and science. And I'm going to start first of all with some data about myelofibrosis. I'm hoping you can see that we've moved to the second slide. If we don't move slides, you need to tell me, because I'm not always great at these sharing data. So the first one is some real world data from, this was produced by Insight. And it's basically a study where they looked at patients and their records from the US. And they looked basically at 3 groups of patients, which you can see on the slide. Group 1, green, are the patients who were treated before ruxolitinib approval and didn't receive it ever. Group 2 is they were diagnosed and treated after the date of ruxolitinib approval but still didn't receive the drug. And then group 3 are the patients who got ruxolitinib in the post-approval period. So there are a few messages, I think, from this. First of all, the power of being able to look at combined medical records. Secondly, that survival for myelofibrosis, at least in this cohort, has improved over time. And there are all sorts of caveats about this kind of data. And then also perhaps that the patients who have ruxolitinib fare better. But I think for me, the more important things were the other points. And this slide just summarizes really the kind of limitations, but it's still very powerful data to be able to pull out. But I think we all know that there are still major unmet needs for myelofibrosis patients. And I asked this question of a group of doctors that we were running a training session for about a month or so ago. And they all highlighted pretty much all of these things. I would also add, in terms of medical management anyway, better access to transplant and better understanding of who's going to do well or not do well with a transplant. But this is, of course, just focused around therapeutics. There are still other major gaps, of course. Fortunately, at the ASH meeting, there was a lot of data with regard to molecules that might be of interest, and I just highlighted a few of them for discussion. And I'm going to focus first on myelofibrosis and then tip back towards ET and PV towards the end of the presentation with a bit of science in the middle. So one of the molecules that's really of a lot of interest at the moment in myelofibrosis is BET inhibitor. So BETs are otherwise known as bromodomain and extra-terminal domain proteins, and this slide really summarizes what they do. So they basically bind to bits of DNA and affect, first of all, the production of inflammatory cytokines, and then also development of hematopoietic cells, principally megakaryocytes. But we do see some action in patients on hemoglobin as well. So there's kind of a biological rationale for these drugs to work. Now, I think it's fair to say that there have been several BET inhibitors that have been developed, and they have not been very successful in patients with MDS and AML. But this drug we've been testing now for a while in myelofibrosis. You've probably been watching it. And there are 3 arms to the current ongoing study. We're going to start at the bottom with the patients who've not had a JAK inhibitor before and look at what happened to the patients where it was combined with ruxolitinib in patients who would otherwise usually be eligible for Rux. So there was no prior dosing with one or other drug, but just both drugs up front. 2/3 of patients had a spleen volume response. That compares quite favorably to the COMFORT studies. But interestingly, the trend over time, initially this was sort of 80-90%, and the trend over time is actually changing and dropping a bit more towards ruxolitinib alone. You can see here they did include some intermediate 1 risk patients at the beginning of this study. So that's another potential kind of question mark about whether response is better because they included those patients. Currently, they're only focusing on intermediate 2 and high risk patients. As you would expect for patients with a baseline treatment with ruxolitinib, spleen responses were quick. That's what you can see in both of these graphics. But if you look at the one on the right, you can also see that the spleen reduction was progressive over time. And maybe that's the benefit of the BET inhibitor in addition to ruxolitinib. Symptom responses were also good. This is a quite tricky drug to handle in clinical practice because you give 2 weeks on, 1 week off. And the pattern for patients is quite mixed. I don't know if anybody on the call knows anybody who's been on this study. There's a little group of manifest trialers on Facebook, I understand, from one of my patients, and they're all experiencing quite similar features. So another thing we've seen with this drug is improvements in hemoglobin. This arm of the study for patients who didn't have transfusions, looking at baseline hemoglobins less than 10 or more than 10. So you can still see there is a dip, perhaps not as much as you'd see with ruxolitinib, but overall the average hemoglobins kind of improve over time. Many studies at ASH focused on what was happening in the bone marrow. At least 2 or 3 molecules were showing this kind of data. So get used to looking at this. Quick primer for pathology. This is what we call a H&E stain. And this shows the megakaryocytes, these very big cells. I'm hoping you can see my pointer. And in this baseline biopsy, they're clustered together, they're very big. And here in this slide, 24 weeks later, the picture looks quite different. This is reticulin staining. The fibers are impregnated with silver, which makes them black. They're thick, they're branched. And so this is roughly grade 3, which reverts more towards normal. This is probably the patient that had the best response. This will be followed up next year, so probably expect to see this coming with a phase 3 study up front for patients where there'll be ruxolitinib in both arms and either CPI or a placebo in the other arm. So they're being very brave and taking this drug right into the first line now, which I'm really excited about. They also had a look at 2 other groups of patients. First, patients who were failing ruxolitinib, and they divided them into transfusion dependent or not. The ones that were not transfusion dependent, they wanted to see what happened to the spleen and symptoms, and the ones that were transfusion dependent, they were primarily focusing on whether they became independent of transfusion, but they also collected data on spleen and symptoms. So this is a second-line cohort of patients. And roughly a third of patients, so that's about average for transfusion responses for MF patients, became transfusion independent, and these are the patients in the study. So variable time up to even 50 weeks for this patient before they became transfusion independent, and the median duration was about 6 months. You have to ask questions about what happened to ruxolitinib dosing, because of course that drug produces anemia, and that's not really available to us, but our experience, and we have about 16, 17 patients on this study at Guy's, has been that we certainly have seen some patients who were requiring blood every 3 weeks who are no longer requiring blood. So that's very gratifying. They saw also spleen responses, perhaps slightly less, but this was adding on to ruxolitinib, not washing it out. And they saw symptom responses as well. And in both of these graphs, the arrows reflect patients who became transfusion independent. So even in patients whose spleen got bigger, some of them became transfusion independent, which is an important thing for a patient. And that's the same here for the symptom responses. And the waterfall plots are color coded according to whether the patients were transfusion dependent, they're orange, or independent, green. They also saw some bone marrow fibrosis improvement. Slightly grayer picture here. They saw 41% of patients had a 1-grade improvement in fibrosis, but some had worsening. So we need to understand how to explain that and how to really know that that's robust. And for me, I would like to see consecutive biopsies showing improvements, and we're not seeing that yet in this study. They also have done the important thing of looking at monotherapy, and I just wanted to highlight that to you as we're going through this data. So does the drug have efficacy on its own? That's an important question. So they've done that in this study. There's a smaller cohort of patients here. 14 patients were transfusion dependent at baseline, 3 became independent. Very similar kind of variable pattern here. For the non-transfusion dependent patients, there were spleen responses with drug on its own. So that's roughly equivalent, but in low numbers for non-transfusion dependent patients, as we would have seen with ruxolitinib in the COMFORT studies. And this is symptom responses. Important to remember, these are open label studies when we're looking at symptoms, so you can feel good because something different is being done about your disease. So I'm always a little bit cautious about symptom responses in open label studies. Here is what the drug's done on its own to patients who had a baseline anemia, the orange patients. So quite consistent improvement. And even in those who weren't anemic, there was still an improvement in the hemoglobin. Low numbers of patients, though, you can see on the bottom. And some of these patients also had bone marrow fibrosis improvement. Probably many of us are wincing at the thought of all the biopsies these patients had, but this is a really important exploratory kind of endpoint that we need to understand a bit more about. Repurposing a cheap drug is something we like doing in the UK, and we've been doing a study looking at Tamoxifen, which we're more familiar with as a breast cancer drug, because it affects estrogen. And the idea behind this was reflected in the gender imbalance that we see in patients and the findings of this man, Simon Mendes Ferrar, who's done a lot of work looking at the environment that the stem cells sit in and the effects on allele burden. So what he found in a mouse model was that estrogen receptors were really important in maintaining the JAK2 positive clone. So in this study, we were basically looking to see, could we reduce the allele burden in patients by giving them tamoxifen? We have to be really careful, though, because this is a drug that's known to be linked to thrombosis. So, and it also has other side effects. So, for example, it can affect libido, something we're not so used to, perhaps, with some of the drugs we give in MPN. So it was quite tricky to recruit patients into this study. But what we did see, and this is a slightly complicated slide, so let me walk you through it, was that we had some patients, 3 here, that had a 50% reduction within 6 months of their JAK2 allele burden, and a group of patients that had what we call a partial response, marked in yellow here. There were also some patients whose allele burden didn't change very much. And you also note that there was quite a lot of fluctuation. So we met the primary endpoint of the study, and the plan is to try to take this forward in some way. But one of the nice things about this data is that there's a really lovely marriage between clinical work and science. So this is an academic study that we did in the UK, and we did something called RNA-seq from peripheral blood CD34 cells in these patients. And using this RNA-seq, we were able to see completely different patterns in those patients who were going to respond versus those patients who didn't respond. So that might allow us to pick out in advance, before we've even started the therapy, those patients who might get this kind of benefit. And I feel you're going to ask me about, well, what about tolerability? So most patients tolerated the drug very well. We did have 2 thromboses during the study, one after a patient had stopped and one on study. And we did have some patients who stopped the drug because they didn't like the way it made them feel, but that was very few. We didn't see any significant improvements in blood counts, but we were recruiting patients who were on stable doses of hydroxycarbamide. No patients in this study were on interferon, because we would expect perhaps to see this kind of pattern with interferon. So back to drug company sponsored studies. So one molecule of big interest in this setting is Navitoclax. Now, Navitoclax is an agent that triggers apoptosis or cell death. And we know that abnormal cell growth and survival is a key feature of cancers such as myelofibrosis. And furthermore, we also know that enhanced JAK-STAT signaling increases the expression of anti-apoptosis molecules. So that's actually described a bit better in pictures on this slide. So just to orientate you, here's a growth factor receptor, here's JAK-STAT signaling. This is what ruxolitinib does, it blocks JAK-STAT signaling. If you have enhanced JAK-STAT signaling though, you get increased expression of these molecules here, these big blue blobs, and these bind out the triggers for cell death. So you have increased cell growth because you block cell death. So you basically, if you combine ruxolitinib and Navitoclax, which releases these red cell death molecules, you actually are affecting the disease in 2 different ways. So this is a different type of combination therapy. So in this study, we're adding Navitoclax to ruxolitinib. Many of you have probably seen some of this data before, but what we showed at ASH was a little bit more biological data. So we looked at patients who had bad mutations, whether they had spleen and symptom responses, and they did. We looked at patients with more than 3 genes mutated or not. This is another group of patients that we know don't respond well to ruxolitinib, and again, they had spleen and symptom responses. And we were also able to show in this study bone marrow fibrosis grade improvement and some variant allele percentage reduction. So that's like we were looking at in the Tamarin study. We're looking at reduction of allele burden, but here the threshold was much lower, just 10%, whereas in Tamarin we're looking at 25 or 50%. And then how do you bring all of that together? So here is a waterfall plot showing patients according to their change in their variant allele frequency. So that might be JAK2 or it might be CALR. And here you can see there was one patient who had really striking reduction. And then the colours relate to what actually happened to bone marrow fibrosis for those patients. So this patient is where everyone wants to be. They've had the greatest fibre grade reduction and the best allele burden response. So this is an interesting way of looking at this kind of molecule. And again, this one is also being taken forward in 2 trials to watch out for coming in your countries. Transform 1 for upfront treatment for patients who haven't received ruxolitinib before. So it'll be ruxolitinib with Navitoclax or placebo. And then a second line study, so-called Transform 2. Here, patients will have ruxolitinib with Navitoclax or be on best available therapy, which could include ruxolitinib or might include, for example, fedratinib in the countries where it's available, etc. So those are the main, some of the molecules of interest, and I want to just very quickly skip through some of the other ones here. So the first one, and there was a lot of data on imetelstat. I think there were 4 orals. So just want to orientate you to the telomerase imetelstat and what that might mean for myelofibrosis patients. So I sometimes describe telomeres as like the tips of the shoelace. So they protect the ends of the chromosome from damage. I was pleased to hear my son, who's at veterinary school, also had it explained in a similar way to him when he was listening to an online lecture the other day. So basically, telomeres usually shorten with age and lead to cell death. But in malignant cells, usually telomerase is upregulated, which leads to protection of the cells and immortalization, if you like. So if you add this agent, imetelstat, which is the only drug that we have available that targets telomeres and telomerase, the idea is that you allow selective killing of the abnormal stem cells. So it's targeting a similar kind of thing that Navitoclax is, but in a different way. So this drug has been around for a while. So this slide kind of summarizes where the drug is. It didn't work very well in solid tumours. It didn't work very well in other heme malignancies. It was tested in ET and MF, and those of you who are familiar with the field will know that about 6 years ago there was back-to-back presentations and a lot of excitement. The data I'm going to present is from a study that actually finished about 4 years ago, but a careful review of the data has allowed interest in myelofibrosis to be resurrected. Recently, this drug with myelodysplasia, which is a related condition, has shown that it can improve anemia for patients and reduce transfusion burden. So it's really being resurrected now in the myeloid field. So the study that they did was called EMBARK, and it compared 2 different doses of imetelstat. It really didn't deliver very much in the way of spleen responses or symptom responses at the lower dose, which was 4.7 milligrams per kilogram. And after they'd recruited some patients, actually they stopped recruitment into that dose and then moved further along to the bigger dose, which was more effective. Here you can see that some patients had transfusion independence, some patients had improvement in bone marrow fibrosis, and surprise, surprise, here we are again looking at variant allele frequency. Something's happened a little bit to the format of the slide, sorry about that. But basically what they showed was that for patients who had the reduction in fibrosis, they had longer survival. Triple negative patients had better survival. And those patients who had a dose-dependent reduction in their variant allele frequency also tended to have tended to have the bigger doses. So you can see here that 100% of patients with a CALR-driven disease had a reduction in the VAF when they were treated with the higher dose. That's really impressive, and we wouldn't see that with interferon, for example. What they saw was that clinical responses correlated with measurable doses of drug. So the better the measurable dose and optimal dose, the better the response, and also correlated with overall survival. And they also saw on-target responses in terms of TERT is part of the complex that is involved in the telomeres. So they saw better responses in the patients that had higher TERT levels, and better responses according to the patients that had shorter telomeres. So again, this is translating into a study. I won't go into the details of this, but I'm excited about it because basically the endpoint of this study is a really important one. It's overall survival. Focusing on anemia, luspatercept again has been approved for myelodysplasia. This is an update of a study in myelofibrosis. They studied it for patients on and off ruxolitinib. And again, we're seeing 30 to 40% responses in terms of patients becoming transfusion independent. And again, that's being taken forward in a study. Just going back to other JAK inhibitors, momelotinib, which is a drug similar in structure to ruxolitinib, but which inhibits the hepcidin pathway. And we'll come back to the hepcidin pathway when we talk about polycythemia vera. This drug, they presented some data, again, from the Simplify studies. This is the hepcidin pathway inhibition function of that drug. So here you can see a survival analysis, which they haven't presented before, from their head-to-head frontline study, suggesting that the patients that received momelotinib did better than the patients who received ruxolitinib, although there is some overlap. And they also showed some transfusion independence and durability of transfusion independence, so which is pretty impressive because the median duration wasn't. Similar data for the second line, but the patients are perhaps doing less well. And here the duration of transfusion independence was between 1 and 2 years. So quite robust data from this study. Here's the overall survival for the Simplify 2 second line patients, which is better than we would expect to see and better than the literature suggests for patients who have failed ruxolitinib. And then I think this is the last bit for myelofibrosis. This is LSD1 or bomedemstat, which has a different mode of action, basically affecting chromosome folding, and particularly affects erythropoiesis and thrombopoiesis. We've seen a lot of data with this drug in recent years. Spleen and symptoms, fairly modest. Here they showed quite a lot of molecular data. This is definitely the ash of molecular data, with a mixed picture, but on the whole, many patients showing some improvement. But they also identified a new gene, because this is a small company and they do a lot of molecular work for their patients. And they found this new gene called BOD1L1, which was mutated in a lot of patients with myelofibrosis. So 7 of their 42 patients were found to have mutations in this gene. So it might be a new gene. So just to tell you about it, it's important for DNA methylation. And loss of function of this protein leads to genome instability, so more likely to have developed mutations, which is what was seen in the BOD1L1 mutated patients in this study. So this is something to watch. This drug, they're carrying on looking at it. They're focusing especially on ASXL1 positive patients. This is where they saw a lot of improvements, and these patients have got challenging mutations, and they will be developing this drug. In fact, there's a study with this drug open in ET, which is really exciting because we don't have very many new therapies for ET, so I'm super excited about that. So there were lots of other things that came up. ROPEG for myelofibrosis, Rux plus azacitidine, TGF-beta inhibition, loads and loads and loads. So happy to answer questions on that. And if I still have a bit of time, which I think I do, I'd like to move on now to talk about Jyoti Nangalia's work on the in utero origins of MPN, new molecules for PV, and to give you some data about a CALR antibody. So this is lovely Cambridge, and Jyoti Nangalia presented this as a late-breaking abstract, and she's done a lovely tweetorial on this paper if you wanted to look her up and follow it. So what she is aiming to answer was questions for patients: how long have I had it for, and how fast is my disease growing? And as we all know, MPNs are really good diseases for being able to check the process of the disease. You just do a blood test, you can measure mutations, you can look at blood counts, etc. Often patients have got normal bone marrow stem cells as well as disease stem cells. Most patients have a driver mutation, by that we mean JAK2 CALR or MPL, and many patients, roughly 2/3, have got mutations in additional genes, which allow you to look back at rates of mutations. So this is beautifully simple work, but tremendously complicated at the same time. So this is really based on a lot of mathematical modelling. So they took 10 patients, these 10 patients listed across here, all at variable ages of diagnosis from 20 up to 78. These patients are colour-coded here according to disease. So blue is ET, pink is PV, and yellow is myelofibrosis. The dots represent when the patients had samples taken, and each sample was plated out. A colony was grown, so that basically represents one stem cell. Then that little colony was, the whole genome of that colony was sequenced, and that was done almost 1,000 times a patient. So you can use the mutations that occur in those colonies as a kind of barcode, and then do a family tree and trace back the origins of the mutations into earlier stages of life. So here, for example, is one such patient, and all of their stem cells, which all kind of grew out in terms of little colonies. This patient has got a JAK2 mutation only, but a few other little changes in the sequence of DNA. And using the mathematical modelling, they could trace back to say that this patient probably developed the JAK2 mutation in their first 2 years of life, sometime between when they were 6 weeks old and 1.3 years old. But they presented when they were 23. Some patients were much more complicated, multiple different mutations, 2 mutations happening very early on. And in fact, this one, a DNMT3A mutation, which we see very commonly in MPN, was acquired actually before the patient was born, probably. Now, this, of course, depends on really complicated mathematical modelling, and there's some caveats around it, but it does suggest that we might be able to track back these mutations very early in life. And it might be possible to enable preventative strategies as the power of genomic testing gets more and more available. Now, the other things I wanted to focus on, which I found really exciting, was calreticulin and the development of an antibody to calreticulin. As we know, calreticulin mutant calreticulin is excreted, and it binds on the surface of the cells to a normal receptor and then can trigger disease. In this work presented from a Japanese group, they developed this antibody that recognizes the mutant form of calreticulin only. Here you can see in this blot, it doesn't pick up wild type, but it picks up the 2 mutant forms. And when given to a mouse, the platelet count was reduced, and the megakaryocytes, we saw these earlier in a bone marrow picture, were also reduced. And here you can see some quantitative work. So this needs a bit more work to do to develop it for humans, but it could be a really exciting new therapy. Also presented was more long-term data with ruxolitinib in a commercial study. I'm not going to show you that. Stopping interferon, which is a strategy that colleagues in France often use, was also presented, and I'm going to show you that in a moment. But first of all, I'll just highlight to you that the PROUD-PV and CONTI-PV study also presented data of a 60-month analysis showing that interferon was associated with reduction in JAK allele burden, whereas hydroxycarbamide wasn't, and that for some patients this was a very deep response. But it didn't translate into reduction in thrombosis, maybe because the number of events was low, and the diseased progression events also occurred, but at a very low rate. A further attractive feature of interferon therapy is that it could be possible to stop it. And I know that's certainly very attractive to some of my patients. But what I tend to do is reduce the dose gradually over time. And Jean-Jacques Kelagin and his team looked at a cohort of their patients in Hôpital Saint-Louis and looked at what happened to patients who could stop. Which patients who could stop could stay off the drug? And they were the patients who had a low allele burden and more than 24 months of response. So they were much more likely to avoid relapse. And after the patients did have a relapse, which means an increase in their blood count, most of them responded to interferon again. So that's helpful if you want to stop the drug, to think about, well, what are the predictors to say that I might be able to stop it for a long time? But for me, it probably won't change my practice. Now, lastly, in the last couple of minutes, I just want to focus on this new drug that maybe some of you have heard about, and a study that was done in America. This drug, PTG-300, was tested in patients with Polycythemia vera. So we've talked about telomeres, we've talked about bone marrows, and now we're going to talk about iron flux. So basically, we're going to talk about hepcidin, which is a regulator of iron uptake. So if you have low hepcidin levels, basically it opens this gate, ferroportin, and allows iron to be taken up through the gut and into the blood. If you have, and then iron is released into the plasma and you can use it to make blood cells. If you have high hepcidin levels, it shuts the ferroportin gate, and ferritin, it gets stuck in the gut cells. You don't uptake it, and you don't have it then in your blood. So then this could be a potential mechanism of action for this drug in polycythemia vera, because many of patients with polycythemia, because they're producing red cells, they are iron deficient. So the ferroportin gate is open because the hepcidin levels are low. So that drives more iron uptake and more red cell production. But in theory, if you give this drug, you close the gate, you could potentially then reduce the hematocrit to normal by reducing the amount of iron that's available to the bone marrow. So what they basically did was they recruited 18 patients. This is a swimmer plot. Each patient is swimming along this row here. This here represents when the patients were first treated with hepcidin. Each patient's venosectional phlebotomy here is marked in a red dot, and you can see immediately that the drug was very effective at reducing the need for phlebotomy. So this is a kind of tantalizing taste potentially of something that might be useful for patients. Here you can see hematocrit levels fell, red cell levels fell, white cell count and platelets were not affected. So if we've got patients who've still got high white counts and high platelets, we might still need to treat them if they're high risk patients. Iron levels normalized, and this may well be important and reflect reductions in symptom scores, particularly for things that we link to iron deficiency, such as problems with concentration, fatigue, and to a lesser extent, itching or pruritus. So I think this is a really interesting window into potentially a new therapy for PV, and I'm going to stop there. Thank you everybody for listening. I'm going to stop sharing, and hopefully now we've got some time for some discussion.
Yes, this is Kapila again, everybody. Dr. Harrison, thank you so much. There was certainly quite a bit happening at ASH, and you've captured it quite well and succinctly. So thank you for that. I do believe we have a few questions, and I would encourage others as well. If you have questions of the content or Dr. Harrison, please throw them in the chat, and we can address them. I know Werner has a question, but it's a related question to another one I just received. So I'm gonna back up a little bit and address Dr. Harrison. You put up a slide at the very beginning about the unmet needs in myelofibrosis, and certainly in other indications as well. There are continuing unmet needs. And we wanted to ask a bit about the prioritization of those. So we've got, needs for more first-line therapies, and need for sort of symptom management and progression management. But in terms of prioritization of those, Are we seeing more discussion or movement about, where the treatment patterns are taking us across those unmet needs?
So I think the first thing to say is I think they're all pressing unmet needs. So I would
Sure.
prefer that we didn't try to prioritize. And I think happily we're tending not to, because a good thing or a bad thing is these tend to be commercial drugs. The only non-commercial drug I showed you was Tamoxifen.
Yeah.
That little study we did in the UK. So I think they're all really important. And if you're a patient with terrible fatigue, that's really important. And right now, that's a massive unmet need. I think what I see from a pharma perspective is of course they need to get their drug approved. So they're going to be looking for the faster route to approval. So I think you can see both of the kind of key front runners in terms of myelofibrosis, I think, are Navitoclax. That's owned by AbbVie, which is a new pharma company for us in our field. They're really keen to get their drug approved, but they're looking both frontline and second line. And CPI from the Constellation, they're also looking in that setting. I think they're all important, but they're not, I'm super enthusiastic about the field.
Yeah. Yes, no, indeed, there's quite a bit of activity here, which speaks to, I think, Werner's question here of these are all wonderful that they're in development and moving along sort of scientifically and in some clinical aspects, but in terms of new approvals and new medications on the horizon, can you maybe speak to the ones that might be closer to approval for patients?
Hey,
to your
Werner.
point about patient impact. Yeah.
Yeah, great question. Well, I think the first thing is we need to get Indrabic available for patients as a second line therapy. Right now we have nothing. Some countries still don't even have ruxolitinib for patients with myelofibrosis, do they? So that's a big issue, and some countries, UK included, don't have ruxolitinib for PV patients. So I think Indrabic obviously coming. I suspect the ones that are closest to approval are going to be, Navitoclax and maybe CPI 610. I think in terms of myelofibrosis, we're quite likely to get approval of momelotinib and pacritinib, but a big problem for us right now is the pandemic in terms of approval, because of our ability to, recruit patients into clinical trials. Most of the time in hospitals, the trials teams are the ones that we would redeploy to support critical care or to support other areas. And there's also a big risk to patients in coming into a healthcare setting. It has to be balanced against, we don't want to stop developing new drugs because patients do well usually on clinical trials, and we don't want to slow the pace of science. And those are the unheard casualties of the COVID pandemic, really, the patients who aren't getting treatments that they need. So I think momelotinib, pacritinib, maybe Navitoclax, if it gets a flying start. I think Besremi is not available as a form of interferon. And we could do with a bit more interferon being available, I think.
That's great. Thank you for that. Are there other questions from the group that we'd like to hear from Dr. Harrison? Or Ken, do you have anything to add to the discussion?
Say, Kapila, can I jump in? This is Rick Winnick.
Go ahead, please.
Rick Winnicker from the MPN Research Foundation. Claire, thanks for your presentation. I think we're all thrilled to see so many late-stage clinical trials ongoing with different mechanistic approaches in combination and alone. I've been thinking more and more, because those trials tend to focus, as they almost need to be, on spleen volume reduction and symptoms, and seeing some results, secondary results regarding fibrosis. I'm thinking more about how do we get to more trials with endpoints that reflect impacting the natural history of the disease, as you mentioned, allele burden, and more trials that start to focus earlier in disease for PV patients and ET, and perhaps even myelofibrosis patients who aren't symptomatic or with large spleens. You know, we hear often about treating these patients when the horse is out of the barn, and we recognize those are the endpoints and those are the most patients that are in most need. But how do we start to move this field more forward toward more preventive strategies, or getting to treat them when perhaps the chance of major success is more likely? I'll throw that out.
Yeah, so I think that's a really complicated question. So one is about endpoints that are valid. So I think, well, look, Gerona's doing that with imetelstat. They're asking a question about overall survival, and you know, they don't care if the patients on the control arm go in another clinical trial. They'll still keep them on and look at their overall survival, and you know, that's really important. Patients want to live longer, but the quality of life piece is also really important. We can't move on with other endpoints unless we really understand them. So at least we've got pharma focusing on allele frequency and bone marrow fibrosis resolution. We need these better surrogate endpoints, and if we get them, then we can look a bit earlier in myelofibrosis, because we know what a surrogate marker would be. But otherwise, for pharma companies, and many of these are pharma supported trials, they don't want to commit to a study with, you know, 500 patients where the patients get followed up for 10 years wrongly, but they don't want to do it. It doesn't make commercial sense. So we have to work with them, or we have to develop academic studies asking that question. And that's the kind of question that you might get from the Tamarin study, for example, if we could expand that. We're asking that question, the question about ruxolitinib earlier in PV at the moment in the UK, but that's an academic study. It's not a commercial trial. So we do need to focus on that, but we need to understand how to focus on it and what the right endpoints are. You know, there's a really good question about, should everybody be on a statin? Or should you double dose aspirin? Or should you add aspirin and Plavix? But in order to do that, you need like 1,000 patients. So we've really got to get the science right. And I think it's really good that, you know, MPN Research Foundation and others are really trying to focus on bringing people together to get the science right. But I also think there's a role for advocacy in working with pharma and working with groups of clinicians, and you all do it in different ways, to try to define which are the important endpoints for patients. Because I think you're quite right, we're not hitting those at the moment.
Peter, yeah. You have your hand up.
Yeah.
Unmute.
Yeah. Hi, Claire. Thank you for being here this afternoon. I have a question for which we probably could use another conference, but I just wanted to ask you, we are getting more and more patients of very young ages. We just had last week, I had a young woman, 18 years old, with myelofibrosis. During ASH, did you hear anything about development of let's only say knowledge, how to treat these young people? And it's not only 19. I mean, I have one with 4 years, with 7 years. I mean, it's because analytical data research is advancing very much. So we are getting, we don't get it back to the utero, but, you know, we're getting closer and closer.
Well, they have the mutations in utero. We just saw that, didn't we? So, but you know, people who have mutations may never develop disease as well. That's important. So actually, we have been focusing on that and trying to understand what happens to young people. We published a few articles on that, just looking at contemporaneous treatment. I think they represent a group where it's really important we do focus. So thanks for asking the question. we are trying to work with MPN Voice to put together a better package for those patients and to provide better support for them. And we've been trying to work as a collaborative group across Europe to make a registry, basically to look at young patients and to document their outcomes. Because traditionally, for example, myelofibrosis that presents in childhood usually lacks a driver mutation and may be spontaneously resolving. That is definitely not the case, as we all know, with adult disease.
Thank you, Claire.
And for the record, my youngest is 2, a 2-year-old. And I think we've come across a young people in Ireland as well. So it's definitely an issue.
And Australia.
Yeah, there was a lovely lady that was involved in, is it Ruby Red or something in Australia?
Yes,
Yeah, she's got a child as well. Yeah. I mean, fortunately, this kind of connectivity and social media means these young people can meet up, and we really need to work to minimise the impact of disease for them. I've got a young boy who's actually in Scotland at university, and he happened to be on some social media package. I'd never heard of it before, some platform, and he said to me, "Oh, somebody in America had typed in, 'Help, I'm 19 and I've just been diagnosed with myelofibrosis. I don't think there's anybody else out there.'" But he happened to be on that platform at that time.
Well, we are coming up on the hour, so I want to be mindful of everybody's time. Dr. Harrison, thank you so much. That was very insightful and a great discussion. And I'm sure there are certainly follow-on comments and questions that if others have, I'm sure we could funnel them to Dr. Harrison in some way for a response. I know we wanted to thank the MPN Advocates Network and Natasha and Michelle for pulling this together for us. And it sounds like we will see a few more of these opportunities to get together as a group and continue these great conversations. So I know Ken and I wanted to thank everyone for joining, as well as Dr. Harrison for putting the time in and engaging in a great discussion.
Thank you all. It's terrific.
Thank you very much. Thank you.
Thank you. Great job of being together, all of you. I would say we're also doing some research on vaccine. I expected some questions on that. Maybe that's for another time. Stay safe, everybody. Bye-bye.
All right.
Bye. Thank you.